Thank you, everyone. Good afternoon. Welcome to Herald Inside LI. I'm your host, Sky. This live weekly webinar series produced by Herald Community Newspaper Group and Richner Live Events launched in August. And our goal is to provide you, our viewers and subscribers, with access to community leaders and information about topics and trends on Long Island, as well as to help answer your questions. All attendees of this webinar had the opportunity to submit a question, which I'll incorporate into today's discussion with our panelists. And if you're tuning in and have an additional question, I invite you to use the chat feature at the bottom of the screen to type in a question, which I'll read to the panelists over the course of today's conversation, and we'll try to get to everyone's questions. Over the next hour, we'll dive into breast cancer and its impact on Long Islanders. We'll touch on the environmental factors associated with breast cancer, if there's an elevated incidence of breast cancer amongst Long Island women, and what it's like for the 1 in 9 women who will have breast cancer in her lifetime. We'll talk about the resources and solutions available during COVID and beyond as patients and survivors cope in our new normal. Before I introduce our panel, I'd like to make a special shout out to our sponsor, Jeannie Ricardo from Better Water, a commercial and residential water filtration company based in Nassau County that provides water solutions for you and your family at every budget. During our discussion, we'll talk about Long Island drinking water and how contaminants may be linked to cancer. So do keep Better Water in mind as a solution for you and your family. This webinar is recorded and will be posted online on our YouTube channel, as well as on Facebook and Instagram. Please continue to visit our website, liherald.com/insideli, to see future panel discussions and events. Tomorrow morning at 10 a.m., I'll be speaking with 4 of Nassau County's elected officials, so please sign up online to join us. Without further ado, please allow me to introduce our esteemed panelists, and we'll dive into this Pink Power live webinar on Herald Inside LI. I have with me Karla Waldron, Executive Director, Mondays at Racine Cancer Care Foundation.
Hi, everybody.
Geri Barish, Executive Director, Hewlett House, and President of 1 in 9, the Long Island Breast Cancer Action Coalition.
Hello.
Adrienne Esposito, Executive Director of Citizens Campaign for the Environment. And Dr. Melissa Fana, Chief of Breast Surgery at Northwell Health. Thank you, ladies, for joining me, and we look forward to hearing what you have to share with us as it pertains to breast cancer. And while, of course, breast cancer is a sensitive and often sad subject, a positive spin on it is the fact that most of the research, discoveries, and advocacy happened in our lifetime. Citizens Campaign for the Environment formed in 1985, Hewlett House and 1 in 9 in the 90s, Mondays at Racine in 2003, and the advancements in screenings and treatments adapts daily on the medical side of things. When I was speaking with Geri before this panel, I learned that the origin of 1 in 9 came to be during a study that Geri did with you, Adrienne, related to pesticides on Long Island lawns. And I'd love for you to share that story with us, Geri. Please, let's start with you, a 5-time cancer survivor.
I would love to. You forget a lot of things and then you go back very far, but when we started, it was in the late 80s, I would say around 1988, 89. And I got very much involved because I had lost a son from Hodgkin's disease. And I had promised him that I would find out why he got cancer. In doing some research on my own, no one was talking about children's cancer at all. So we started to talk amongst a group of people about what was going on in Long Island. This hormonal, which we found out breast cancer was a hormonal disease. My mother had died of breast cancer. I had 2 bouts of breast cancer by that time, and thought, let's start checking around and seeing if there's other people. 2 women who actually were our founders. We were all the founding members, but our founders were 2 teachers in the school district in Long Island, 2 bouts and 3 bouts of breast cancer. We started asking questions. No one knew why this one had it, that one had it. There was a high rate in teachers. We started looking at pesticides and chemicals and the environment. I grew up on the water. I mean, Long Island, certainly every place you look, there's water. And we said, you know what? We always felt that water was responsible somehow for us getting breast cancer. But we needed, of course, to prove it. And so we got in touch with Marion Moses, who's a scientist in California, and that incredible lady who's sitting over there, Adrienne, who knows more about the environment than I could ever think I do. But we had a lot of problems in the beginning because no one wanted to talk to us about the environment. They thought that we were all lunacies. We didn't know what we were talking about. And we stuck together and we looked at pesticides and we looked at pesticides and chemicals and learned that, Long Island had the most open waste sites in any one place in any one state. I mean, most golf courses in any one place in any one state. There was so many things. We got together with the Farm Bureau, who in the beginning certainly didn't like us. But we started asking these questions. And Marion Moses suggested that we look at a pesticide registry and start seeing what was happening with the leftover chemicals or pesticides that the gardeners used or farmers used. And actually the farmers were pretty innocent. They did what they were told to do. So we put together this pesticide registry. It took us 4 years to get it passed in the state of New York. People thought we should leave, that how dare we, do this, that their homes would go down, and it was awful, but it worked. And those little yellow things that you see on people's lawns were what was from our pesticide registry. We hooked up a health research science board to look and see what was going on. There were a lot of pesticides that were stopped being used. So it was a beginning. It was just a beginning. And we realized we had a very long way to go. We knew nothing about genetics. There was so much we didn't know, and it became a good beginning. I'll let Adrienne, I guess, take over.
Well, hello, and thank you for having me. I just want to accent, what Geri said. Our organization started back in the 1980s, just yesterday. And, we started out wanting to, and we still work to, protect drinking water. And as Geri said, one of the big issues was the issue of water quality. Hopefully, many of the viewers know, but some of you might not, that there's 3 million people who live on Long Island, and we get 100% of our drinking water from directly underneath our feet. It's in what's called aquifers, which simply means layers of water mixed with sand and gravel under Long Island. So we don't have magic springs that come from Connecticut, as sometimes people tell me. That's not true. We don't have upstate water where it magically comes from New York City and comes out to Long Island. That's not what happens. Everything we do on the surface of Long Island, if we use pesticides, there's a leaking gas station, a toxic waste dump site, from dry cleaners, all of that percolates down and unfortunately mixes with the groundwater. So as Geri said, one of the issues that was extremely concerning in the 80s and 90s, and still is today, was the fact that many of these pesticides are what's called hormone mimickers. So they will mimic female hormones or they'll block male hormones. So there was a whole book written on it called Our Stolen Future by Theo Colburn. Terrific book. I read it several times back in the 80s, so I memorized it. But really what it means is that pesticides are chemicals designed to kill. That's what they do. So when we put them on our lawns, because we want to kill a weed or kill a bug, we also end up killing birds, and we have to think about how do they impact humans. If they're impacting the hormonal system of that bug or that bird, what is it doing to humans? Mm-hmm. And I think it was a great pairing for the breast cancer movement to match up with the environmental movement. I remember I went over Geri's house once, and these women were sitting around a table, and there were maps everywhere, and then we were sitting down with maps and pesticide use, and it was honest, real, genuine, grassroots, work that was getting done and needed to get done to raise awareness about drinking water, but also pesticide exposure and how this impacts all of us, male and females, by the way.
Right. And when you say grassroots, you literally mean the root of the grass.
In this case, yes, that's true.
So, no, I'd love for Dr. Fana to weigh in now that we're getting into some of the medical part of this with the hormones and the pesticides. And is it true that, there is a link, and what does the medical field talk about when it comes to this topic?
You're on mute, doctor.
Unmute you.
You have to take yourself off. Don't you wish you had $1 for every time you said you're on mute in 2020?
Yes. So, hi, everyone. Thank you for having me. We know that on Long Island, there's a higher than average risk for breast cancer. We also realize that this risk is affected by certain chemical compounds, etc. We also know the risk factors for breast cancer, which include having less children. The way I think about it is mothers are protected by nature against breast cancer. So if a woman starts having children at the age of 20, has 5 children, she's less at risk for breast cancer than if somebody started having children at 35 and had 2, or someone never had children. So the years that a woman has unopposed estrogen and progesterone, the amount of years increases the risk of breast cancer, early period or early menses, late menopause. So who are these women, and are they on Long Island? Yes, women of higher socioeconomic class. I don't have children, unfortunately. I did not think of family planning when I was a young medical student or resident in training, so I do take a lot of consideration when I have female residents or medical students rotating with me to talk to them about the options that exist. Breastfeeding helps against developing breast cancer, but if you don't have children, you don't have an opportunity to breastfeed. Family history, very important, along with genetic mutations like BRCA1, BRCA2, but we've learned of many, many other genetic mutations, and these genes, we all have them. It's having abnormal copies. So,
and now that you mentioned the genes specifically, someone asked a question, if they did take the BRCA test 16 years ago and it was negative, does that person need to be retested?
Interestingly enough, 16 years ago or 20 years ago, a lot of us were testing just for a BRCA1 abnormality or BRCA2 abnormality. But today we have much more sophisticated testing, which includes upwards of 36 genetic mutations, which are associated with breast cancer. So the answer is always consult with your doctor about updated testing. I have to say that insurance companies are very open to the idea of paying for testing because it is a preventative measure. So they do save money in the long run if they identify an individual with a genetic mutation that they could prevent the cancer.
And now that you mentioned insurance, when Geri, you have information about insurance, people have questions whether they can get a second opinion about something and if insurance will cover multiple opinions.
Yes, it will. I mean, there's a lot of things that we took up and fought for legislation. And one of those is that you are entitled to get a second opinion and a third opinion. Your insurance company will pay for it. Prescription is written, and you need to have that comfort zone with your doctor and understand your history. And before you can undergo surgery or any kind of treatment, you need to feel comfortable that you're doing the right thing and you need to move on. And insurance is such a nightmare that we got involved very heavily in that, and that you are. Also, the genetic testing, I mean, Myriad is phenomenal. If you call them, we've dealt with them, and they will work with you to make sure if you need to get that test, you'll get that test. The counseling part of it is very important as well. But I think the insurance issues change on a daily basis today.
Right.
And I'm constantly on the phone dealing with insurance companies and trying to explain to people about their rights. It's one of the things we push for and teach, that you are a patient, but you have patient rights, and not to be afraid of them. You can call the insurance company. You need to ask questions before you just say, okay, go for it. And then when you get that bill at the end, you say, but I gave you my card. Guess what? You aren't covered for everything. So as a patient, it's very important for you to understand before you go into surgery or whatever you do, that you understand what you're paying for, what you're covered. Because once you sign on that line, that's too late. Another law is that if you go into a doctor's office, for instance, they are supposed to have where you can actually see what insurance they take. Legally, you go in, and if you don't see, you ask that question, and then you turn around and get a bill, there's a problem. So there's lots and lots of things that we have learned and that we fought for, and that's very, very important.
And I know that Hewlett House and 1 in 9 and Mondays at Racine, these are groups that support groups that with other people going through the similar process. And I'm wondering, I could imagine that the impact on everyone's mental health, especially during COVID, it was a heightened state of anxiety. Maybe you couldn't go get your screening or your test on the date that you were supposed to, and maybe it was delayed. And then, God forbid, your prognosis is worse now than it might have been pre-COVID. So I'm wondering, Karla, with Monday at Racine, and also Geri, how your groups help people in this situation now. And we'll start with Karla.
Thank you. I just want to ask a quick question about what Geri and Adrienne talked about. When you guys started your registry, or when you did your registry, was that what spawned or triggered the mapping of Long Island in the mid-90s, when they were mapping for the hot spots of cancer?
Well, yeah, because we really didn't know, where they were. We walked door to door and knocked on doors. We found out that a cluster was 2. I mean, when I think of a cluster, I think of, oh my God, all these people. But if you knock on the doors and there's all kinds of other diseases and there's only 2 cases of breast cancer, that's a cluster. So we had a fight to go into a registry. What did you live on? What did you live around? Were you on a dead end street? I mean, all of these things, what were you on top of? And they all, through what Adrienne was able to bring forth, and for the knocking on those doors and looking at who lived there before, what happened to those people. And another interesting thing is that they said, they would give out numbers. And for instance, there was an area that they said there was 1 out of every 4 people had breast cancer. And it's like, are you kidding me? So panicked. But people didn't know how to read the maps that were released from the Department of Health. It was per 100,000. So if you had 400,000 people in an area, that was what it was. So there was kind of panic too. A lot goes into that, and we've come very far. Believe me, we have, in understanding and asking those questions. But with PERC and so many different chemicals and dry cleaning establishments, what was underneath the gas stations, the leaking, your backyards where you had boilers and things, cesspools that were never tapped off or closed off, monumental. And when you live in a house or you grow up in an area and you start asking those questions, so we decided that we needed to knock on doors. We needed to, go and see what was going on. New York State I think in 89 or 90, our registry was 10 years behind.
Wow.
New Jersey had what was called a gold registry. How come we were 10 years behind? Because nobody knew who was sending up the information to the Department of Health. Was it the doctor? Was it the nurse? Was it the record room? So Senator Tully asked us to come to Albany and to rewrite certain questions and to look and see where there was the mainframe computer system who was putting the information in. It was so, Adrienne said grassroots. It was so grassroots. It was starting from scratch. If someone moved here from another state and they were diagnosed in the other state, so they weren't put into any kind of a registry here. But if you lived in Long Island and you were diagnosed in Manhattan, You weren't in the Long Island registry. You're in New York. You're in the Manhattan registry. So
Wow.
all of that is people don't understand that kind of a thing. It's a very, takes a lot of education.
Well, I'm so glad you guys did that work. I mean, it's monumental.
Yeah.
And I think the more information we all have as women, the better we all are. Information is power. And I don't know if a lot of people believe that environment really does have that much of an effect. I happen to think it does, but I'm lay. I'm not an environmentalist. But I really am enjoying this conversation. But for Mondays at Racine, we're seeing people who are going through it. They're already in treatment. They are, whether they're just diagnosed or mid-diagnosis or mid-treatment. I feel like going back to your question, Sky, about the anxiety and about the ancillary services that Geri's practice does and my organization does. I think they're so important because they really do aim at reducing anxiety. And I think that somebody like Dr. Fana, who refers a lot of her patients, thank you, Dr. Fana, to our organization, she might hear every now and then, oh, that massage I got at Mondays at Racine really helped me sleep at night. And then just that little snippet of a patient being able to sleep better at night, that does wonders for a patient. That does wonders. And then you multiply that over and over again with all the other services we provide. I think that what COVID did, our programs had to be closed because we're not a vital service. We were dealing with a population who, was very at risk. So what we did was we thought really quick on our feet. We pivoted and we provided a lot of at-home services that we were able to do through Zoom. And we had a lot of one-on-ones going on, and those became so popular. I could not believe how popular they are still to this day. They're going to become evergreen for our organization because some patients just still don't want to leave their house. And I get it and we respect it. But for the patients that are coming back to our programs, like I said to Geri before, I feel like we are busier than ever. It is like through the roof, people clamoring for services. Of course, our services are free. So, and you don't have to, reach for your insurance card or open your wallet. And you can go to 16 different places all over Long Island to get our services. We have 17 oncology approved services. But it's nice that they don't have to worry about money and they don't have to worry about anything but themselves and get some of those services to help them, be reminded of the beautiful person they truly are and not just this cancer diagnosis.
So what are some of the services now that you can provide through Zoom that maybe you wouldn't have thought of prior to COVID?
Definitely meditation, group meditation, one-on-one meditation, chair yoga, regular yoga. I have nutrition services, beauty consults. So like we can even show a woman on Zoom how to, when you lose your hair, you lose your eyebrows and you lose your eyelashes. So we could show people through Zoom how to apply a lash or how to draw on a brow. You name it, a lot of consulting, but even my Reiki masters have now somehow figured out Reiki through Zoom. It blows me away. It's way beyond me, but they do it and it's remarkable.
So, and what about in telehealth, Dr. Fan? I know that these programs that Karla's speaking of are free and done through your nonprofit. And what about in telehealth? Are you seeing that you can treat patients differently or console them or consult them through telehealth or through Zoom?
So interestingly enough, I mean, it's not likely to find many positives through a pandemic, but this is one of the positives that has come out of this unprecedented time. 3 years ago, I approached our leadership, our chair of surgery, and said, I want a platform, an online platform where when a woman gets diagnosed with breast cancer or a radiologist has a biopsy result that's positive, I want it to automatically link to me so that that person doesn't have to wait more than an hour or two before they have the solution to their problem. And in creating, the minimal liability and the platform and strategically thinking about this, which wasn't easy, now it's simple because it was desperately needed. And so telehealth has opened up channels in which someone who's diagnosed with breast cancer can now have an immediate point of contact with me in my office, and we can get the ball rolling in terms of additional imaging, genetic testing. We do use Myriad, as was mentioned. It is the leading company. We have pre-authorization set up. A patient does not have to worry about paying $3,700 out of pocket. Through my office and our centers that I manage, if a patient has a bill, I tell them, bring it to me. If you have a bill that you don't recognize, et cetera, we will help resolve it. But these things can also be handled through telehealth. If a patient sends us a message and says, I need to talk to you, I have my genetic testing on Friday, and the counseling left me with a couple of questions, I jump into a consult that same day. So it's really fascinating, amazing, and it's going to stay as part of our management strategy.
It really is nice to hear some of the positives, and I see a lot of nodding, and I'm sure that your programs, like you mentioned, you refer to each other, and it seems like that's a good system, for a support system for people going through this.
I mean, Monday at Racine is an essential component to the care that we provide patients. When I have a patient, it doesn't matter the age, the first thing I do is ask if they have a cell phone, which mostly everybody does. Take the cell phone, put Pandora or some free music app on there, and tell them to start listening to the music they listened to when they were 16 or 17 and walk with that music, etc. But being able to offer Monday at Racine's and survivorship or coalition services to those patients is invaluable.
Mm-hmm.
Oh, thank you.
I want to revisit the topic of water, since this segment is sponsored by Better Water, a at-home and commercial filtration system that you can have in your house. And Adrienne, you mentioned Long Island has these aquifers. We get all of our water from underneath us, and how there could be a link between these pesticides. That's what we looked into it. The studies about the link between these chemicals and hormones. And I'm wondering if there's anywhere else in the US or in the world that is comparable to Long Island with getting water from an aquifer, and maybe have they seen similar things with correlations with cancer?
Well, Long Island is actually what's called a sole source aquifer, which means 100% of the drinking water comes from underground. We are designated as that by the US EPA, and there are about 12 or 13 other places in the nation that also have that designation. Long Island does have the dubious distinction of being the most densely populated. As I said earlier, it's 3 million people. So 3 million people working and playing and living on top of your aquifer. And it's not just pesticides. Pesticides are documented to interfere with hormonal development. And there are studies that look at pesticides and finfish development. And in one study done right here in Jamaica Bay, we saw that 90% of the fish made a leap from being in their sexual development to becoming feminized, 90%. So it impacted the development and the reproductive development of finfish, and that was exposure to pesticides. But again, this is not just pesticides, right? Where there's a whole, I'm sorry to give bad news, but potpourri of different toxic chemicals. And if you just look at the scientific literature about why these are considered toxic chemicals, it's their relationship to what they do to the human body, whether it's a nervous system disorder or specific cancers, breast cancer, liver cancer, kidney cancer, lung cancer. So different chemicals have correlations to different cancers. And unfortunately, on Long Island, there's over 120 pesticides and pesticide breakdowns found in our groundwater, small levels, trace levels, but they're there. Small levels and trace levels of a whole list of volatile organic chemicals, small levels, but they're there. And there aren't any scientific studies about what's called the synergistic effect, or the compilation of having all of these exposures at once. So if you eat a peach, and I'm picking on peaches because they have the most pesticides on them when they go to market. I think it's 9 or 10 different types of pesticides. And then you drink a glass of water and there's trace amounts of VOCs. And then you sit down and you eat rice that's not organic and you get more trace amounts. So all of these cumulative impacts add up. These are exposures that are not fully understood. They are not fully studied. They may never be studied, frankly, because it's so complicated. And the very small amount of studies I've read on what's called synergistic effects are just when they combine 2 or 3 chemicals and they look to see how they react. But we literally have 10,000 chemicals we're exposed to on a yearly basis. So when people say to me, do you think there's a correlation between environment and health? I don't understand how anybody could say no. Mm-hmm. It's not just all, hereditary. It's not just all bad luck or bad genes. A lot of it is life choices and life decisions, or just unfortunate, circumstances where you worked in an area where there was exposure, you lived in an area, you didn't know that there was toxic soil in the playground. We have multiple routes of exposure on Long Island, and it is of concern.
So what do we do? How do we prevent this? We can get screenings, get a mammogram, but also, are we not supposed to drink the water? What are people supposed to do to prevent?
Well, let me just say this, and then I'll be quiet. I forgot to say this. 30, 40, 50 years ago, the water was not as rigorously tested and treated as it is today. So the good news is that today, as a minimum, if you live on Long Island, if you don't have a private well, if you have a private well, call me. We need to chat. But if you don't have a private well, it means your water is being tested at least 4 times per year or more. And if there's something in your water that exceeds the state or federal standard, the water, a supplier is by law obligated to filter your drinking water. So it's being filtered down to at least the state and or federal standards. So that actually is good news. I want people to know that. People ask me all the time. We get questions at the office all the time. But do you filter your water? Just tell me if you filter your water. Mm-hmm. Yes, I use a Brita because it's activated carbon. It gives just an extra little oomph before we drink the water, we make the tea, just to be sure, because an activated carbon will filter out your volatile organic chemicals. So that's as honest as I could be. I'm not supposed to support any particular drinking water filtration system, but that is the truth.
Okay. And during the recovery process, oh yes, Geri, please.
I just want to jump in for a second because it's so funny, Adrienne, you just brought me all the way back to, the bottles and all that other stuff. But I think it's truly about good education, getting the information out. And I have to tell you, we work with a lot of young kids because we do all cancer. And the first thing a kid will say, well, how do you know if that's good or not? Kids are so smart today. And we say, you see that little skull and crossbone on there? That means danger. And so, they'll look at those kind of things. We'll give them resourcing to do. But we need to do a better job in educating our youth, our kids in school, because they go home and they talk to their parents. And I think that we're just not getting enough of a good education out there, between COVID and we had Sandy first. And all I could think about was when we had that horrible storm, was all of those pipes underneath the ground that were maybe 200 years old that were breaking up apart and coming out of the shower and all of those things. And, we stopped spraying a long time ago for many good reasons. And we have to make sure that we need to learn how to read labels and understand what that is. I mean, how long have we been fighting to teach people how to read a label? What does it mean? There's an 800 number you could call on when you look at something and ask, is it inert ingredients? Is it not? I mean, it's teaching, it's education, and kids are incredible. But I think we're missing that today. We really are, because
I just want to say, I totally agree. And remember, you won't remember this, Sky, but perhaps the other panelists is when they used to spray for mosquitoes and they would spray DDT from the back of the truck. in the
Sure.
60s and the 70s, and the kids would ride their bicycle and go in and out of the spray, you know, and now DDT is directly correlated as a hormone mimicker to breast cancer. So we did a lot of dumb things that we just didn't know because the science didn't exist. But hopefully we're getting smarter and we're getting better.
And when you talk about education and teaching kids about danger and signs, so when should that education begin? In the schools, you think that kids should be taught about this in public schools?
100%. I mean, why not? What's more important to a child and their family than their health?
Mm-hmm.
I mean, and even in our, in America where we are a little conflicted about issues, I think the one thing we can agree on is that we value our health, and it should be placed with a high, if not the highest priority. And it's a necessity, not a luxury item.
Agreed. Kids are incredible. The schools have got to go back to basics.
So I could imagine that when people come visit you, Karla and Geri and Dr. Fana, they're already at the point where they may have a diagnosis. So are these things that you find patients and recovering patients still worry about with when it pertains to the environment and other factors? And, the education may kick in then for them to start teaching their families.
I think so. I think we need more. I'm sorry, I didn't mean to interrupt, but you don't read a lot about the environment as much as we used to because there's so much going on out there. People are so panicked about COVID, and people come in and they'll say, well, my cousin or my aunt or whatever was just diagnosed, or my uncle with prostate cancer. And we heard that, now you have to be careful with breast cancer from prostate cancer. And then they start asking us about the environment, what they live on, what they don't. I personally think we need to get back to a lot of that. We're not paying enough attention to the environment and what's happening. We're locked in, and I get it. With our masks, we're trying to protect ourselves. And even with the masks, I see people wearing 2 and 3 masks, and I go, what are you doing? They're so afraid of getting something, and they're not even wearing the right mask. They're not protecting themselves in the right way. So it's all about outreach and education and keeping your fingers crossed. And if you have a lucky butt, you're okay.
Mm-hmm. Now, someone asked about antiperspirants and if they are linked to breast cancer.
There's so many different products that I remember way back. Don't use underarm deodorant, don't use this, don't use that. I think it's reading what the product is made from, what's in it. We know a lot more now than we did then. You have to really learn to resource and learn to.
But are you supposed to look for ones without aluminum? I've heard that. Is that true?
Well, I think we should ask the doctor. I've heard that also, and so I just would not buy one with aluminum, but I defer the Dr. Fana.
And I'm fortunate to have a multidisciplinary team that approaches cancer from different angles, and my patients get all of the support and necessary vehicle to provide the education that they need. For me, obviously, it's a different setting. When I see a patient with breast cancer, we have one acute goal, and that is to cure the breast cancer, to get rid of the breast cancer. And then it is survivorship to minimize the chance of the cancer returning. And we have a survivorship program at Inbrook Cancer Center, where I primarily work. And we have another survivorship program that was created out of Peconic Bay for Suffolk County, which is amazing. And then we have Monterey Cancer Center. And now we're opening up a cancer center, or actually enhancing a cancer center in Huntington, so patients are provided that education. But from my perspective, when I have someone affected with breast cancer who has extreme anxiety and stress about a myriad of factors, should I convert everything I'm eating immediately to organic? Should I stop using deodorant? I basically provide the education necessary about what products are more favorable, which ones aren't, but the goal is to get them through the breast cancer treatment and then And then we implement a strategy for afterwards.
Mhm.
I like that, Dr. Fana. I want to just say too that when someone is going through a horrendous diagnosis like that, the last thing we want to do is start to make anybody feel guilty about choices that they've made.
Right.
Really did not know, unbeknownst to them, they were just living their lives. And the problem at hand is to get them through this particular time, and while working on educating and while working on getting them to where they need to be. But this information is all relatively new, and it's not by anybody's fault that nobody asked to have cancer. Nobody said, well, I don't care about the information out there, this is what I'm going to do. And the information is slanted, it's politicized, it's a million different things. I think we're getting better at disseminating good, real, smart information, but I always like to err on the side of making sure our patients or our clients have less anxiety. Our nutritionist actually is one of the busiest people on our staff. Unfortunately, you get a diagnosis and you forget how to eat. You're like, oh, sugar, oh, soy, oh, this or that. I mean, the information is wild and it's coming at you. So I think there's just real stable, good, solid information that's, I think, agreed upon across the board. And of course, I'm an advocate of eating organic. Can I eat organic at every meal, at every single time I eat a food group? Definitely not. But I think we're getting there,
Mm-hmm.
Yeah, I agree. I mean, look, I'm a crazy environmentalist and I can't eat organic at every meal either. Absolutely. But what I do find is, more and more people are really kind of getting the understanding that, when we're exposed to all of these chemicals, it's probably not good, but we've become so used to it. Like you just said, people live their lives, right? You go to the store, you buy deodorant. You're not looking to see aluminum. It's a heavy metal. It's going to build up in my bloodstream. It's bad for brain development. People aren't thinking about that. All of these products on the shelf, you assume they're safe. And you think everybody's buying them. They must be safe. And as we know more and more with current science, the truth is, and this is what's very difficult, and I know it's difficult for everyone who's listening, but a lot of those products are actually not that safe. We tested 80 common household products for this chemical 1,4-dioxane. It's not an ingredient, doesn't have to be listed on the label, but it's a byproduct of the manufacturing process. It's a highly toxic chemical, causes cancer. All of the literature agrees on that. And then we found it, in Tide, 14,000 parts per billion. Victoria's Secret bath gel. We finally found out what Victoria's Secret is, and she's poisoning us. It's 17,000, 16,000 parts per billion, way over any kind of a standard. So it is natural for people, all of us, to go to the store and think, I'm just buying this stuff off the shelf. And unfortunately, regulations and understanding hasn't caught up with the marketing skills of these major industries.
Yeah, and people are becoming more savvy, I think. I think population is just getting more savvier by the day. So
Mm-hmm.
I will add that the opportunity that at least we have and I see in my practice is my high risk clinic. So any woman that is seen by myself or my nurse practitioner for any breast related issue, even if it's just breast pain with negative imaging, what we do is we calculate their lifetime risk. When I'm giving lectures and I ask a large audience how many women or men in that audience know what their individual lifetime risk for developing breast cancer is, and when I give those lectures to healthcare practitioners, not many hands raise. But when we calculate individuals' lifetime risks, we stratify them to a high-risk clinic where we do monitoring clinical examination twice a year, and we may or may not add MRI to screening. That's the opportunity that we feel to educate in terms of these preventative environmental and lifestyle strategies, implementation of lifestyle strategies, knowing their own normal on breast examination, not necessarily conducting an exam every month, but knowing your normal so that if something changes, knowing what factors in your life can impact your risk further of developing breast cancer, and then genetic mutations as well. I have to say that through a grateful patient who was not mine, the patient was Dr. Karen Kostroff's, the patient donated an amount of money that was then utilized to purchase genetic tests. And in 2018, in my practice, we diagnosed over a dozen patients who did not meet formal recommendation. They didn't meet qualifications for genetic testing, and we identified them with genetic mutations that put them at elevated risk for developing breast cancer. Some of those patients are under high-risk screening and education, as we're discussing, and some of those patients had risk reduction surgery. So I just wanted to add that that's our opportunity within the practice to implement this.
Now, Dr. Fana, when you say that those patients didn't meet whatever qualifications they should have, what is the difference in those qualifications?
So genetic testing is applicable for patients who had elevated lifetime risk of greater than 20%, while an average American woman has about a 12% lifetime risk. That's average. A lot of factors are utilized to calculate a patient's lifetime risk, including family history. We have a Gale model risk score that we calculate, but the Gale model score doesn't incorporate second-degree family relatives. So we utilize Tyrer-Cuzick. A lot of insurance companies look purely for these risk factors and calculated lifetime risk to approve spending money on genetic tests. So we had patients that didn't meet those standards, and yet they were identified with genetic mutations, which is also eye-opening.
Wow, it just makes me wonder about genetic testing. How do they do that? That's a blood test?
Yes, it is a blood test or saliva. I mean, we have very advanced technology now. You know, I've even had relatives of my patients who tested positive for a genetic mutation, maybe PALB2, CHEK2, BRCA1, and they tell me their sister lives in Iowa and there's not a breast cancer specialist there. And we mail the genetic test after setting up a session for genetic counseling. Somebody mentioned, I think it was Geri, how great Myriad is in also providing genetic counseling for free. And so we set that up. We could set it up virtually, set it up through a telephone conversation. And statistics and data show that the effectiveness and satisfaction of a patient having an in-phone or virtual consult for genetic counseling versus in person is equal or even superior. So we've identified genetic mutations even like that, distant relatives or close relatives in other remote areas.
Fantastic. Fantastic.
Yeah, it really is fascinating. And about that BRCA2 gene, if someone has that mutation, what's the likelihood that they will develop breast cancer?
So BRCA2 is distinct from BRCA1 in its risk factor for breast cancer. BRCA1 up to 87, you might hear up to 90%, they just average it, of developing a first breast cancer. BRCA2, 50 to 60%, and in some literature, they might quote smaller numbers, 20 to 40%, or even as low as 12%. It really, I think, you know, it depends on the literature and the data that we're reviewing. But so we take the biggest number, 50 to 60%, offer breast risk reduction surgery. But with BRCA2, the interesting thing, as opposed to BRCA1, it's its risk factor for also ovarian cancer and the different incidence of ovarian cancer with BRCA2 and BRCA1. So if a patient, this is really something I'm very, very proud of in collaboration with Northwell and our different surgical subspecialties. Dr. Ben Schwartz is our gyne-oncologist in the Suffolk County region, South Shore University Hospital. He also goes to Huntington. Dr. Adam Perry is a plastic reconstructive surgeon out of South Shore University Hospital. He's the chief of plastic surgery, partnering with Dr. Neil Tana and Dr. Mark Smith, who came to us from Manhattan. I always tell patients in Long Island, don't worry, the city has come to you. You don't have to go into the city for high quality care. But we developed a multidisciplinary surgical center, primarily focused at South Shore University Hospital, where when patients were identified with a BRCA1 or BRCA2 mutation, even other mutations in some cases, who would benefit from salpingo oophorectomy, removing the tubes and the ovaries and removing the breast, we would combine the surgery. Plastic surgeons can remove the belly fat connected to artery and vein and reconstruct the breast with that belly tissue. So everything is done at the same time. It's about an 8-hour surgical procedure. If a woman was going to remove both breasts and have that belly fat reconstruction, it's still 8 hours. So it did not increase the amount of time under anesthesia. Yet a patient benefits by reducing the risk of ovarian cancer and breast cancer without necessarily having to think after going through one risk reduction surgery that next year or in 2 years, now I have to do this again. And we know from the data that a lot of patients don't comply with doing that second surgery, feel overwhelmed, feel scared, or even if they're undergoing screening methods, there's really no good screening method for ovarian cancer. So we're really proud of being able to provide that combined surgery.
It's really cool what science and medicine can do. It really is.
I'm a big fan of Dr. Schwartz. I think he is phenomenal. He actually was on our board for 3 years and did us a great service while there. So I think if anyone's looking for, we highly recommend you and Dr. Schwartz when we're asked. So that's what Mondays at Racine becomes. And I'm sure for Geri too, we become this major resource center in addition to providing services. And it's amazing that we have advocacy just for resources. Like we are becoming very, very trusted, and it's only because of the people we're referring and you know, and recommending that has happened. So I love Schwartz. I love him so much. I hope I never have to have him as a doctor, but I do love him.
It's excellent.
Now, Dr. Fana, are prosthetic breasts, is that still common practice?
Yes, and actually earlier today, I gave a lecture on the advancements we have made from a surgical perspective and treatment standpoint for breast cancer. I mean, I do have to say, I have the utmost respect for women who have gone through breast cancer treatment 20 years ago, 30 years ago, but I do have to say that what we're able to offer now, I couldn't be prouder. We perform nipple sparing or skin sparing mastectomies with immediate reconstruction, whether that be with a direct implant or with your own tissue. Now, implant reconstruction usually requires, I'm sorry for that, usually requires an expander or deflated implant to be placed immediately at the time of surgery, but not always. We have better surgical techniques. We have, if the flap is viable, meaning if the blood supply is really good, we have very expensive machines and technology that Northwell has purchased for us to look at that blood supply and be able to do immediate implant reconstruction. So the patient wakes up and they're essentially done, or if they're using their own breast tissue. So I think that in terms of the emotional, psychological, and physical aspects of going through treatment and surgery, it really is just a level up to be able to provide that for a patient when they know that after surgery, they could rest assured that they're pretty much done in terms of that and can move forward and sort of release all the anxiety and stress of you know, a second or third operation.
Wow.
I think that's so important, Dr. Pennant, what you said today, you know, in retrospect from so many years ago, it's a whole different ballgame. And when people come in, a lot of them are very, you know, they're afraid. They don't have any idea about the different surgeries that they can have. They're afraid of the time and things like that. And there's so much going on out there today that we're able to, as support groups and centers where we do, you know, meet with doctors and find out. It's incredible. I mean, I wish I had what I had today, not so many years ago. I would have done so many things different, you know, but it's amazing. It's really amazing.
Even the chemo pill, I think that the chemo pill is, you know, people are just living their lives not having to have intravenous chemo, you know, and I know it's not for everybody, but I think that's amazing. That's an amazing, you know, place to be right now.
Yeah. Do I have time to ask the doctor one more question?
Yes, of course.
Okay. When you talked about the genetics and the testing, we only talked about women. So today, because I think of, you know, men are now getting tested as well. Sometimes a woman will come in and her family, there's, you know, there's no cancer and they're looking and they say, well, your father or your grandfather or someone can be tested and should be tested. So I think it's a whole family. It's a whole different ball game when we look at the educational and the risk factors. I think that has turned itself around. That's so important. when we look at not just our daughters, but our sons, and that there's other, I mean, I had breast cancer 3 times and then first had, you know, the genetic testing, and I did not, I was negative. And yet someone said, how could that be? The test was wrong. We didn't understand. And I think education out there is giving us an opportunity to learn so much about genetic testing. And it's really so, so important. So thank you for what you're doing with risk factors. That's incredible.
That's very important what you just mentioned, because, you know, even when primarily my patients are female, but even when their male partner is in the room, I have to stop myself and say, I'm sorry, what's your name? Let me incorporate you in this, because they're vital. And I extend my information, my personal cell phone number to the partners or husbands. But yeah, 50-50 chance of inheriting a genetic mutation. If a male is a carrier of the BRCA1 mutation, not only are they particularly at risk for prostate, pancreatic, colon cancer, breast cancer, but they have a 50-50 chance of passing that mutation on to their children. If they had 4 boys, potentially 2 of those boys may carry that mutation. It could have implication in their life or their children's lives. So it's very important. You know, I recently had a patient who was young, 27 years old. And we were talking about genetics and how that plays a role, especially in young women. Out of 100% of patients presenting with breast cancer, 7.5% approximately have a genetic mutation that we know of. 12.5% family history, which that may be a genetic mutation we don't know yet. But she jokingly said to me, oh, it was my father. You know, my mother divorced many years ago, and he has so much cancer in his family history, and he wasn't a good dad. And we joked around. I said, it's a 50-50 chance of inheriting it from your mom or from your dad. Turns out it was her mom. So even when we have a significant family history of cancer, we think that the likely suspect is a particular person of carrying the mutation, that may not be true.
Thank you. Yeah.
So there's a lot that we've learned, and we have to wrap up now. It's 5 o'clock, and thank you so much for everything that we learned here. We talked about the environmental factors affiliated with cancer, the treatment process, the recovery process, and the advancements on the science part, and in the medicine part. It's chilling, all the cool new things that are out there. So thank you all, and I do want to take a quick picture of all of us on the screen together if you want to smile. Great. Thank you again. And I'm going to put up my little thank you slide. And I appreciate everyone who took the time to tune in here, and to our panelists, especially for sharing time out of your valuable schedules. And thank you so much. And we hope that you'll continue to tune in to Herald Inside LI. And I'm sorry if we didn't get to your questions, and please submit more questions online, and continue to tune in and join us tomorrow at 10 a.m. when we'll be online with Nassau County elected officials talking about government stuff. All right.
Thank you, Sky. Thank you, everyone.
Thank you.
Bye, everybody.
Thanks so
Thank you.
much. Bye. Have a good night.